Thank you very much indeed. Welcome back, everybody. I think we're just waiting for Michael. Ruth, yes, please do come back onto the stage. Michael, if there are 2 seats, yes. Yes, Michael. It'd be like, what's the saying? The party without, the right person. Yes, I think it would be good to have you on the stage. Even though he's not going to speak. Thank you, Michael. So this is our final session this afternoon. We're going to be talking about making the review a reality for Europe, member states and local areas. And to kick off this, Agis, you're going to just talk to us a bit about governance, the issue of governance for health equity, and then we'll have some of our panel members.
One of the issues that was rather neglected for a long time in our efforts to achieve results in engaging other sectors has been the issue of understanding governance, understanding how the world works, how decisions are made. And for a long time, we have been using a wide range of terms such as healthy public policy, intersectoral action, multi-sectoral action, health in all policies, which is a more recent term, whole of government approach, whole of society. The issue here is that in our understanding of health and its determinants, we always assumed that somehow, because we had the facts, that other sectors will immediately turn their houses, their homes upside down to fit to what we were telling them, reorganize their priorities, reorganize the way they make decisions to just embrace health. Well, that's not true. It doesn't happen like that. And in fact, today, one of the facts of life is that decisions that relate to health are increasingly complex, are increasingly interdependent, the result of interdependent policies that happen at all levels, at local level, at global level, at national level, at regional level. And if we are really serious about implementing the health, the social determinants review recommendations, we have to be serious about governance. Governance for health. And we make a distinction in the Health 2020 between health governance, which is mainly within the walls of the health sector, because governance is not a new term, and it's been applied in all sorts of different contexts, including clinical governance. But governance for health recognizes that responsibility that other sectors have, other stakeholders, through the impact of their policies on health, or through the contribution they can make to health, and in all sorts of different ways. And here is the challenge. The challenge is, A, to acknowledge that health is a global good. It's something that it's not only the output of one sector, but it is the output of a whole of government, a whole of society. It is something that we co-produce in our society. And in fact, we have understood that a lot of that contribution will come from outside the health sector. Then we have to think about the mechanisms to make it happen. I mean, previously Michael was referring to joint up government. I mean, there are all sorts of ways to refer to partnership-based approaches, like shared governance, integrated governance, democratic governance, governance, whole of government approach, and so on. The idea is to first of all, create awareness about the importance of health, about the role that different sectors will have. Second, to create mechanisms, both formal and informal, that will enable this interaction, this integration. Nothing is linear in this world. Basically, the world is messy. And the idea of finding a perfect model to make decisions about health will never work. But what we do in the context of different countries, different situations, we try to navigate, to find pathways that will create circumstances of partnership, common understanding, common planning, joint accountability. In other words, to bring health to the fore as a common goal and a common value. And that's what it is all about when we say whole of government approach, which can be interpreted as mechanisms that enable different sectors to sit around the table, institutional arrangements, but also the other side, which relate to communities, to people, their ability to take part in decision-making, their ability to have a say and to have a voice. As you hear again and again, this is a major part of this great strive for better equity. People at the center, people to have the possibility to be engaged, to have a voice, to have influence, to have control. That's the whole idea. So, are we starting from scratch here? No. Is the evidence strong enough to do this? Yes, but we shouldn't be making the mistake to think that you put in an envelope the Marmot Review and you send it out to the Ministry of Education and you expect the Minister of Education to somehow fall off his chair or her chair. It will not happen because we need the skills to negotiate with the education sector, to see where they are coming from. We put forward to them that early life is important. Great. Are they interested in education in early life? Of course they are. Are there policies for early life? Of course there are. What are we talking about? Tuning policies, integrating policies, creating policy coherence around the family, around the child, around that early stage in life. So, in a way, we need to be good diplomats. I always thought that public health is half politics and half science. We need skills to go out there, to negotiate, to convince, to engage. And the result is not always a joint committee, nor is the answer to all this a joint committee. The result may be, okay, let's keep each other informed. Let's try to align what we are doing. Let's find a common language to communicate what we want to do. Do we agree our children are our future, our most precious and valuable asset in our society? Of course we agree. So we need to navigate this landscape of evidence, of policies, of politics in a way that fits well the origin of and the reality of the context in which we live today. You will never achieve the goal of getting our children slimmer if you do it through somehow one-sided, siloed approaches to, let's say, to the Ministry of Education to teach children that it is not good to drink sugary drinks, or to maybe the transport sector to invest more in cycling lanes. We need to create an understanding of mutual gains, of co-benefits through investing in policies that ultimately can contribute to health. So that's the issue. Governance for health. Health 2020 is putting a lot of emphasis on this. And one last comment, because we talk about the power of evidence. I will give you an example. What is the strongest instrument the world has today for addressing a major public health issue? I would say the FCTC, the Framework Convention for Tobacco Control. Powerful stuff. even stuff that has been ratified by governments, that you have laws and protocols and obligatory processes. And yet, is the evidence clear? Powerful evidence. Does the finance sector have a key role? Absolutely. In dealing with taxes, with the pricing, with the packaging, and so on. Is it easy to knock on the door of the finance sector and say, hello, here we are, we have the FCTC, we have the evidence, we expect you to react to this? It doesn't happen. It really takes an awful lot of effort to get all the relevant sectors around this common issue of tobacco, to have smoke-free places, to have support for people to give up smoking, to do the packaging, the taxes, the illicit cigarette smuggling, and all the issues. You need a host of sectors, but you need a good diplomacy, a good policy to get them to work together, even when the evidence is as powerful as in this case. So this is our commitment. We don't take this lightly. We are not planning to take the review and just stick it into envelopes and disseminate it, although I have to underline the fact that translating all this into different European languages is going to also make a very big difference. You cannot reach out to the broadest political and policy-making community by distributing stuff that is written in one language. We have to invest in that, and I hope this will also be governance, dissemination, awareness will be key in taking this one step forward towards success. Thank you.
Agus, thank you very much indeed on the importance. You talked there about how you're not talking about joint committees and so on, but people talking and so on. But I mean, is that enough? There must be other instruments, surely.
There are, and in fact, there is a lot of. We have done 2 studies identifying good practices. But what I wanted to avoid is when we talk about intersectoral action and whole of government, some people say, okay, what you're talking about is setting up a committee. The answer is not the committee. The committee may be one of the mechanisms, but it is creating that culture through awareness, through understanding where we are coming from, creating some common vision, common goals, and then we will figure out how to do it. I'm saying it's a little bit more complex and probably simplistic to think that everything boils down to just 10 people sitting around the table.
Okay, good. Thank you. All right, well, let's hear from our next speaker, David McDade. He's a senior research fellow in health policy and health economics at the LSE and political science and the European Observatory on Health Systems and Policies, and his work focuses on the economics of public health, particularly on actions for better mental health and well-being, and he's a lead author of a publication that's just coming up now, highlighting the economic as well as public health case for greater investment in health promotion and disease prevention, and that's what you're going to be talking about now. Thanks, David.
Absolutely. Thank you very much, Zainab. Good afternoon, everyone. I'm going to spend a very brief amount of time wittering on about money, because money is another one of these things that we don't like talking about very much sometimes, but it can also be a very powerful tool in making the case for investing in prevention, promotion, but also doing things across sectors. So having common responsibility for a budget, or seeing the benefits, as Agus was mentioning, financial benefits to the education sector in the education sector's language can help a lot, as one example. So I shall witter on a bit about that. And I shall skip over some slides in the interest of time. But what I do want to say, why think about economics anyway? Because I do argue quite strongly and that it's important to have these money arguments, because maybe people in this room don't find that so much of a priority, but a lot of people will do, particularly when there are competing claims on resources. And it's about whether or not every single thing we do to achieve better health outcomes, to tackle inequalities, what sort of trade-off is there in terms of the amount of investment we have to put in to achieve that? What are the costs? What are the benefits, not only to the health sector, but to other sectors as well? And clearly this requires a cross-sectoral approach, whole of government, and all the other things that we've heard about. And of course, this costs a lot. For those of you with super eyesight, you'll be able to see there are big numbers on this slide. It doesn't really matter what they are. The point is there are big numbers all across the world associated with poor health status, with chronic health. And the potential thing to think about here is whether or not investing in prevention can avoid some of these costs. Does it actually have a return? Does it further support the arguments and the evidence we've heard from earlier today? And again, I could talk about actions across many different sectors. I can't do in the interest of time, but you can identify economic arguments in all of the sectors I've put up here on the screen. So what do we know? Well, actually, we know quite a lot now about the economic case for investing in promotion, disease prevention, injury prevention. There have been a considerable number of studies. We have one just coming out that we've worked on in partnership with the OECD, which looks at a number of risk factors to health, but there are other studies as well. There was work for the Chief Medical Officer last year on the economic case for prevention in England. Work we did for the Department of Health on mental health promotion in 2011. Work in Australia, more work from the OECD. So there's plenty of stuff out there arguing that there is an evidence base on things that work, and not only that, there's an economic argument as well. Let's take some of the issues that have come up in this meeting today. Early years. Now, this is a great area from an economic point of view because it's actually an area with a lot of evidence that there is an economic payoff. And people much grander than me, like James Heckman, and who's a Nobel Prize-winning economist, have shown that there are economic returns by investing in the early years of life. In fact, from pre-birth all the way through to leaving school, you can identify returns on various interventions, and some of them we've heard about earlier today and are included in the report. Why is this important? I just show one slide from a study in New Zealand, the Christchurch study. I show it a lot, 2005. It shows children on the left-hand side who had a poor status of mental health at the age of 7. They had behavioural problems, conduct problems. And it shows on the other side children who on the right-hand side it's the severe problems, on the left-hand side no problems. The differences at age 25 in outcomes are stark. No one went to university in the severe group compared to 30-odd% in the no-problem group. Much higher risks of being unemployed. Much higher risks of becoming a teenage parent, having a lower income if you're employed, more likely to be in prison. Lots of profound impacts that go way beyond the health sector and have a profound impact on life. So there really is strong evidence that if we do nothing in childhood, the consequences in adulthood can really be substantial. Horrible slide here. This is a Canadian study, but I do want to say a couple of things very quickly about it. It's been following an intervention in schools, preschool and in school, an education and health intervention for the last 10 years in Ontario. And the important thing about this intervention is that at the moment, what it's showing is that it's costing more to the health system to do this. But there is a saving to the education system over 10 years because there is less need to invest in special education, remedial education as they call it in Canada, to actually get a return. It's cost saving if you think about the impacts across sectors and not just in the health sector alone. And there are many other studies in the early years area. There's the work of David Olds in the States that's been going on for years, looking at the role of family nurses. Interaction with family nurses in the first years of life makes a huge difference. Parenting programs we know about. We know about other interventions to promote social and emotional health in schools. And they have good economic returns as well as being effective interventions. And let's not worry about that slide in the interest of time. We mentioned family and parenting support programs. Again, there's an economic evidence base to support some of those. Work by David Stuckler and colleagues suggesting that if we spend more on family support programs, then it can help mitigate some of the risks of unemployment, and unemployment in turn, the risks it has on psychological health. I've gone through that quickly, but there is, believe me, a strong evidence base on the economic case for investing in early years interventions. What about the area of welfare and work? Well, we've heard already today about the profound impacts of not doing anything about this, and I've just highlighted one here, which is the impacts of long-term unemployment. Now, work by Garcia and Vaguero indicates that in Sweden, during the Swedish recession in the 1990s, it wasn't actually the period of recession where the risk of suicide was greater. It was actually after the recession was over and those people who were still left behind as the long-term unemployed, they had a statistically significantly higher risk of suicide at that period, and you'll have to trust me, that's what the slide says. Okay? So this emphasises another key area where there is a growing economic evidence base as well as effectiveness evidence base on activation in labour markets, helping people to find employment, including labour market training, special programmes for young people, helping with the transition from school to work. Also, though, crucially, there's an evidence base now growing, particularly in places like Hungary and Sweden, on the importance of psychological support for those people who actually lose their jobs, so that you maintain your emotional strengths and resiliences to actually go seeking work. And there's an economic payoff associated with that. And again, referring to the work of Stuckler and colleagues, their active labour market strategies are associated with positive impacts in terms of helping to reduce the risks of suicide. I want to mention another area, and again, the numbers are too small, but a key area I think to think about as well is financial debt. We know from this country at least that the risk of unmanageable financial debt is associated with a much greater risk of developing common and indeed severe mental health problems. Particularly if you're borrowing money from the loan shark or the weekly pay loan company, the Wongas and all that kind of stuff, with high interest rates. They are associated with much higher rates of depression, anxiety disorders, and the rest. So is that not an area where we can think about investing as well? And we did some work for the Department of Health in 2011 where we looked at the economic case for investing in debt advice and counselling services to try and reduce the risk of unmanageable debt. Ideally, I'd like to go upstream and think more about financial literacy in the first place as well, but we only looked here at debt management. But what we found is that there is an economic payoff by investing money in not-for-profit debt advice services, say those run by something like the Consumer Credit Council or the Citizens Advice Bureau. And it has a payoff there is a payoff in terms of improved health because you reduce the risk of depression, but there are also payoffs to the justice system by reducing the legal costs associated with court cases and pursuing debts and so forth through other means. So there's a payoff there. So that's another risk to think about, which has got nothing to do with the healthcare system, but has an impact on health. Horrible slide again, but basically that's just saying we also know that there is a strong economic case now, and I could cite lots of studies on this, for investing in workplace health promotion programs. There is a payoff to employers, there's also a payoff to the economy as a whole, and this is an example for mental health related programs, but you can find the same thing for physical health as well. The third and final area is social exclusion and isolation. We know here again that there are important benefits associated with people, actually, in the most simple sense, talking to each other, actually having a conversation, not being isolated. Participations in group activities can make a difference, and we know something about the economic impact that has, for instance, in terms of the need to make use of health and social care services. But it also has there are other things we could think about as well, and I've cited one example here about walking and cycling. You may think, what's that got to do with social exclusion? But actually having environments, towns, where it is actually possible to have the choice to walk or to cycle, not being excluded from that because you live in some dodgy part of town is an important thing to think about. And it has an economic payoff. I mean, this is a study in The Lancet, and basically what it's showing is that over time, the more walking and cycling you do, the better economic return and health return you get for a whole range of chronic health problems. And there are community actions and other things we could talk about as well. For older people, it's a life course thing we have to think about as well. We know a lot about the powerful benefits of group interaction to reduce the risks of social isolation and the impacts that has on physical health and mental health, and indeed things like reducing some of the risks around sustaining an injury when falling if you participate in group exercise programs. I've really gone through this really quickly in the interest of time, but I'm just really trying to say that there are economic arguments. A lot of the data, though, it has to be said, is from the usual suspects, from Western Europe, Australasia, North America, and we have to think very much about how it applies in different contexts. There are issues about engagement, about equity, and about uptake. It's no good having fantastic interventions if no one actually uses them or no one wants to use them. So that's an important issue as well. We have to think about investing more money for effective interventions to reach those who may not otherwise be reached. And in building that into our economic analyses as well to help policymakers. So finally, I would like to say and to argue that there is an economic evidence base, of course it's not perfect, that supports actions to reduce some of the risks to health that we've heard about today. Of course it's uneven, but there is an evidence base there, and it's certainly something to build on. There are benefits, economic benefits, certainly to the health sector, but in many cases well beyond the health sector. Things I've not talked about today, things around transport, around the environment, around the benefits of better physical activity and better diets. There are benefits that go way beyond health that have been quantified in good, robust studies. And this is very important if we are trying to sell these messages. And I hate the idea of being a salesman, but it is important to try and sell the evidence base in many different ways. So the economic argument is one additional weapon to try and make the case to policymakers at national level, at local level, and at international level to take action. And combined with that, it's important to take the evidence we do have and think about how it fits in our own local contexts. So I hope that's of some help. Sorry for going through things so quickly, but I really want to say that money does talk and money can help, even if sometimes we're a bit uncomfortable thinking about money. Thank you.
David, you talked about, the need for the economics. Help. You presented the case of the economics of health promotion, but when you're selling this to politicians, what kind of time scale are you talking about? Because obviously they're interested, in a much shorter time frame than people like you might be.
No, I totally accept that. The good news is that okay, there are some interventions that take many years to realise a return. We should be absolutely upfront about that. But there are actions also that can have a return in a much shorter time frame. I mentioned actions at work. You can argue that the actions taken in the early years of life have an immediate benefit in terms of classroom behaviour, less teacher absenteeism, where that's been evaluated in some studies. So there are short-term benefits as well. But we should not shirk away from the idea of investing in the long term and moving beyond sort of political circles where we can. But there are short-term impacts as well as long-term impacts.
Thank you. And we'll let you off with your slides. Sorry for the people at the back. You must have thought you were looking at the Rosetta Stone at times or something, Yes, but there we are. That was quite clear. Thank you very much, David. Kevin Fenton, you're going to come and give us your perspective talking about tackling health inequalities in England, because Kevin is from Public Health England, where he's the National Director for Health and Wellbeing, and in this role you oversee Public Health England's national ill health prevention and health promotion programs, and you also look at the social determinants of health, don't you? So please do give us your presentation.
Wonderful. Thank you so much, and good afternoon, everyone. It really is a pleasure to be here with you this afternoon, and I'd like to begin by congratulating colleagues for the release of this report, but most importantly, the conversations that we're having this afternoon about moving from theory to action, thinking about implementation in a more systematic way, and holding ourselves mutually accountable for success. Now, in my presentation this afternoon, in the short time I have available, I'd like to build on the conversation that you've heard today. We've, in this session, began by reflecting on the importance of governance. We've then looked at the evidence for implementation. In my talk, I'd like to use the creation of Public Health England as an exemplar for ways in which structural change can be used to help us all to advance the changes that we need to see as far as implementing the social and structural determinants of health. So what I'm going to be doing in the next 7 minutes or so is, first of all, begin by briefly introducing Public Health England, speaking a little bit about who we are, why we're interested in implementation, ways in which the structure of the organization can work with the new system and new partners within the system to drive implementation and translation, and then finally end by just reflecting on some worked examples of ways in which this implementation is currently ongoing. So, Public Health England is a new agency. We were created on the 1st of April of this year, and our mission is highlighted here. It's to protect and improve the nation's health and well-being and to address health inequalities. It was established on the 1st of April and brought together more than 100 different organizations under one umbrella organization, PHE, with 4 regional offices, 15 centers across the country, and of course the national office as well. What's exciting about Public Health England is that for the first time we now have a national function and a national leadership function on health improvement that looks towards systematically working with partners to address health improvement, health inequalities, national social marketing functions, and promoting well-being. And that's the part of the agency which I now run. The key reputation and credibility of Public Health England is really going to be determined and predicated upon our ability to work with all partners in this new system. Local government is now the seat of public health leadership, commissioning and action, so public health's role as providing expert advice to support local government will be key to our success. Public Health England will also play a critical role in working with a range of partners, including the Department of Health, NHS England, again, local government, the voluntary and community sector, business and other corporate sectors, to ensure that we are aligning our efforts to advance health improvement and health and well-being, but also to address health inequalities as well. Now, a key part of what we do in the agency is to focus on implementation, and nearly every part of the organization is really focused on looking at the existing infrastructures in place and ways in which we leverage these to drive health impact. Now, unfortunately, the font on this slide decided to shrink, but essentially what this is showing is that there are different parts of the agency, whether our operations directorate, which works very closely with local government, helping to provide evidence and support that local government partners need to deliver effective programs. We have a knowledge and intelligence directorate that focuses on leveraging information, knowledge, and data, ensuring that that is provided to our key partners and stakeholders to advance health improvement and health and well-being functions. My directorate in health and well-being also is clearly involved in looking at the science and the evidence as it relates to the management of lifestyle conditions, non-communicable diseases, and ensuring that the evidence as far as prevention and control of these conditions are disseminated and used to inform public health programming at the local level. So each part of the agency is involved in implementation, and each part of the agency therefore has a vested interest in ensuring that we are looking at health inequalities, looking at the social and structural determinants of health, and factoring that into our implementation efforts. Now, as an agency, there are a range of priorities that we're currently being focused on. Some of our key health improvement priorities are highlighted here. We are committed to reducing deaths and ill health associated with a range of lifestyle conditions, including smoking, high blood pressure, obesity, poor diet, poor mental health and insufficient exercise, and alcohol use and abuse. Focusing on preventing and recovering from conditions with the greatest impact, including conditions such as dementia, mental ill health, including anxiety and depression, and drug dependency. We are committed to focusing on the life course approach, thinking about ways in which we provide more holistic programming to give children and young people the best start in life, for example, through supporting programs such as health visiting, school nursing, and family nurse partnerships. We also have a focus on health and well-being in the workplace and looking at the workplace and workplace interventions as an opportunity to advance our health improvement and health inequalities portfolios, and of course looking across the public health system to focus on system-wide capacity development, looking at professional, scientific and delivery expertise both within the agency and within our partners as well. So as we think about this new agency, as we think about our commitment to implementation, here are some of the priorities in the health improvement domain that we'll be applying those techniques to in the months and years ahead. Now, as a new agency, translation and implementation is critical for our success. We know that we're not doing a very good job of implementing what we know works, and we know that even when we do implement what we know works, we're not implementing at sufficient coverage and scale to have the impact on population health outcomes that we need. We need to do a much better job in England of ensuring that we are bridging the gap between what is known and what is actually done, and what is actually done and what is actually scaled for impact. And we know that this is not a new problem within the health and social care system in England. In fact, there have been many other reviews of translation and implementation, which says that as a nation, we tend to be far too slow with implementing some of the most effective interventions. And therefore, we fail to have the impact that we need to have at a widespread level because of this failure of dissemination, translation, and implementation. So not only are we seeing this in the health and social care system, but we're also seeing this in public health as well. And I believe that the creation of PHE, Public Health England, does give us an opportunity to address this. Now, as PHE enters this space, I think there's some challenges as well as some opportunities that we need to keep our eyes focused on. Clearly, as we move towards a more decentralized model for delivering, commissioning, and thinking about public health priorities, there is a real danger that increased localization and the localism agenda may result in us not being more than the sum of our parts, that we may be pulling in different directions and therefore missing the bigger prize in addressing the wider determinants of health and well-being within our country. And we know that as a system becomes more devolved, it becomes perhaps more difficult to mandate large-scale replication and scale. So as we have created this new system and structure with the transformation of the health and social care system in England, it is really important that we use this opportunity to create stronger bonds and ties to ensure that we become more than the sum of parts. Now, there are amazing opportunities ahead. We have strong links as an agency with our colleagues and partners working in other government departments, as well as with a range of national organizations which provide support to local systems and local partners, including NICE, the Local Government Association, a variety of professional bodies that can be pulled together to help us to think through implementation objectives and strategies. We also have, within the structure of the agency, a variety of structures and relationships that we need to leverage and to build upon in the months and years ahead to ensure that we as an agency are fit for purpose to help this process of implementation. Now, this map is here only to show that as a national organization, we have both a regional presence as well as a local presence, and each of those 15 centres within Public Health England is really tasked with working really closely with local government colleagues, working with local partners in the voluntary and community sector, creating a seamless interface between national, regional, and local to think about ways in which evidence is translated, ways in which we can hold each other mutually accountable for implementation, and to facilitate greater learning and dissemination of best and promising practice. And that will be a key part of what we'll have to do moving forward. Now, there are some great examples where we're currently doing this work of translation and implementation. And this slide just really shows a few of the evidence-based interventions where we as an agency are committed to supporting local partners to implement and to scale. Starting with the lower left-hand corner, the Family Nurse Partnership Program, as many of you know, really looks at intensive one-to-one support provided to young mothers to ensure that we provide the best chances for infants and young people to give them the best chance in life. This has been shown to be highly effective. It's a national priority. PHE has a role in supporting the translation, the implementation, and scale-up of this program with our local partners. But there are many other interventions which are currently being identified and delivered at the local level where we need to do a much better job of learning from those implementation challenges and opportunities, doing a better job of sharing and promoting the dissemination of best practices at the local level. So, for example, many local authorities have already begun to implement 20-mile-per-hour zones. Others have begun to implement play streets. Others have looked at improving child asthma management programs, all of which which are evidence-based programs, all of which have demonstrated return on investment and are a good investment of public health dollars. The question that we have ahead of us is how do we ensure that we leverage the new system to learn as we're doing, to share best practices, and to accelerate the dissemination of evidence. So in closing, what I wanted to do today was really to create and to continue this conversation about implementation, to build upon what we've heard today about the importance of governance, the importance of science and evidence, but to use the creation of Public Health England as an exemplar where we have structural change occurring within England and ways in which we should be using and leveraging that structural change to facilitate implementation and translation. Now, this is incredibly important as we think about how do we move from theory to action when it comes to implementing our approaches on social and structural determinants of health. I would argue that now more than ever we need to think globally but act locally. Public Health England will have a role in helping to facilitate this, both through our coordination efforts, also through our commitment to using knowledge and evidence, but most importantly, by the strength and the bonds that we create with our local partners to facilitate better and faster sharing of information, dissemination of best practices, and of course, learning as we're doing. Thank you very much.
Thank you. Yeah, do sit down. So thank you. Just to give you an idea of the kind of things that people are saying on webcasts, I mean, just comments. Dear colleagues, thank you for your important contributions. Your recommendations will be used immediately by me and my local colleagues. That was from somebody in Sweden. Somebody else, I've been following your presentations the whole day and I'm very inspired by the ever-increasing evidence you're presenting. I'm also very glad for the recommendations you're making. What I would like to see in future is our closer links to sustainable development. Excellent presentations. Will the slides become available? And somebody's saying, what else are they saying? Thanks for asking my question. Don't know which one that will be. Will video be made available after? Yes, is the answer. And somebody said, as a blog editor for AM.Journal of Preventive Medicine, I've been watching since 4 a.m. in San Diego. So there you are. One question we had, and I'll just throw it to you very quickly, David McDade. What will be the impact of the UK's government policies of cutting the top rate of income tax and subjecting welfare benefit claimants to conditional programmes, including workfare? What effect is that going to have on inequities in the UK?
Well, just a little question.
Yes.
I think the way I would answer that is to say that there is an evidence base, certainly, that indicates that things that may lead to a restriction in access to welfare benefits may have adverse impacts on health. I wouldn't like to comment so much on the impacts of the top rate of tax, because that partly depends, well, I think it's best to say that. But one other thing to add, it's important to do an impact assessment of the potential of a tax change.
It may just be worth going to Ole. I don't know if you've got the microphone there, but you talked about social protection, obviously, and welfare policies, and we haven't really talked about this issue of taxation. But looking at one of the questions that we had earlier about the implications of what we're discussing in Europe for other countries, and that came from Nigeria, you do see in countries like Nigeria where the government there is trying to increase its tax raising revenues in order to fund welfare programs and social protections of the kind that you were discussing and saying that had a clear impact on, social inequities. So there is a link. I don't know if you wish to make a comment at all on what we've just been talking about.
Well, of course, there's a link, and the link is, it's a perpetual chain there where high employment rates generate more tax revenues that could be used for various social programs that could sustain high employment rates, etc. But of course, I think the problem sometimes is that you become locked into a certain system, that if you have a logic of one system, people act in that way. So it might be difficult for some countries to introduce taxes where taxes might have been very much needed for investment in social policies. And that's a problem. But otherwise, I think that several countries, like the Nordic countries, seem to operate fairly well, even on high tax levels. And the reason for that is, traditionally at least, that the middle classes and upper classes have got something in return for their high taxes, which is an important lesson, I think.
Yeah, thank you for that. Okay, some comments from the floor. Microphone ushers, if you could see hands are raised, and maybe just position yourself near the hands. Any other hands raised? There's one here. Yeah. If the young lady with the microphone could give it to the chap in the purple shirt. Yes, do stand and introduce yourselves, please. It's easier than people at the back can hear. Yeah.
Thank you. My name's Richard Parrish. I'm not too sure which hat I'm wearing today, but I chair the National Pharmacy and Public Health Forum and sit on the advisory board for Public Health England. A couple of observations very briefly that are interrelated, if I may. The first is that even though I'm sure we have a very substantial evidence base drawing upon a whole range of disciplines, I'm absolutely certain that we do not deploy that evidence base in the way that is understood by many of the people that we wish to convince, either in terms of the policy arena or indeed of the public. And that's also related to the whole question of how we use language in the public health field. It's Jenny Poppet's point, really. And if I can give you one specific example that Michael and your colleagues may wish to take on board. We talk about non-communicable diseases, which has meaning for us in public health. But I think the inference of a non-communicable disease for many politicians is it's your own individual responsibility. It tends to defer the responsibility. And yet we know from all of the evidence that Michael and others have given us that non-communicable diseases are in fact communicable diseases. They are mediated through a whole range of societal vectors, social, environmental, and economic. And that, the mere fact that we use that language, I think, helps politicians sometimes dismiss the importance, which is why we sometimes see greater attention paid to communicable diseases. And if we were able to redefine and reuse the language in a better way, we might, for example, be able to use in a more persuasive way the whole question of empowerment being seen in the same way as immunization is with regard to communicable diseases. Empowerment would be a way of immunizing against NCDs for the future. So it's a plea really for us to think in public health outside the box and to use the perspectives of the people that we wish to convince, and then perhaps rephrase and redeploy the arguments that we put forward.
So what would you call, I don't know, diabetes, obesity and so on, the non-communicable diseases?
I would call those societally communicable diseases. They are communicable diseases, in my view, in the same way as other communicable diseases.
So from NCDs we go to SCDs.
Well, I don't mind, but it's about how we convey a slightly different conceptual way of viewing these things.
And Kevin, I mean, it is the non-communicable diseases that account for the lion's share of health budgets, isn't it?
Increasingly, and certainly we see in the United Kingdom, and certainly in England, the increasing burden of these diseases and the increasing toll it's having on the system. Richard, I think I like where you're going with your comment. I wonder if there is a fundamental issue here, though, of literacy around these chronic or non-communicable diseases that we also have to ensure that we're doing at a national level as well as at local level in England. We have historically placed structural, financial, and human capital into our infectious disease prevention and control over many, many decades. And I think the creation of Public Health England gives us, for the first time, a chance in a national public health agency to reset that balance. So in addition to changing the nature and the terminology that we use, I think we also have to do a bit of basic education, awareness of policymakers, of our key partners on some of these issues.
Okay, all right, thank you. I will come to the panel at the end. And Ruth Hussey, Chief Medical Officer of Wales, thank you very much. Welcome back. Very briefly, Richard, and then...
Very briefly, and I've got a voice that carries.
Yeah.
Thank you. I absolutely agree with that. The fundamental point that I'm making is that if we were in the world of marketing, we would start where our consumer is. We would look at the way they perceive and they understand the messages we're trying to put forward. We don't do that in public health, by and large. We start with where we are, not with where they are.
Thank you.
Great,
okay,
thank you.
Gentleman there.
Peter Archer, Chartered Institute of Environmental Health. Be very short. We must wish Kevin well at Public Health England, but are you going to ensure that local authorities now delivering public health do deliver it? We've had a Secretary of State, Eric Pickles, close the Audit Commission. There is no one out there regulating local authorities and their general services now. and we've already lost £2 billion from supporting people. It's no longer a ring fence. Directors of finance are spending it on roads or whatever they think is appropriate. The public health money is currently ring fenced. Are you going to ensure that Jeremy Hunt doesn't remove, or George Osborne doesn't remove the ring fence?
George Osborne there, the Chancellor of the Exchequer, for whoever's listening on the web. Yeah, other points? I'll come back to you in a sec, Kevin.
Great.
No? Oh, good. One hand there. Yeah, microphone right at the back. Yeah, thank you.
Hi, I'm Tarvi Tillman, a public health trainee. And because we have quite a lot of global audiences listening too, I thought I'll quickly comment on global health inequalities, particularly the earlier comments about redistribution and possibly increasing or reducing taxation of the wealthiest, which is a very politically sensitive issue, particularly perhaps in our circles and circles of our friends. But what hasn't been mentioned is the massive international competition that prevents that from happening. So if we increase taxes here, the rich will go to other countries, and perhaps offering an idea that maybe there should be more international, coordination, and streamlining of that issue. And perhaps one day we could be looking at labeling countries that offer obscenely low rates of income taxes for the wealthy, something such as rogue states that we should possibly enact trade sanctions against, because that's just completely unfair in a global, unified world we're living in today.
Yeah, that's a relevant point. And in fact, I think one of our earlier presentations talked about the fact that, social health has an impact. Global factors have an impact. When you look at the Roma community, and their status has got to do a lot with, migration policies that are, transcend national borders and so on. So thank you for that. Yes, a gentleman here at the front.
Good afternoon. My name is Zengs. I'm a student and I have some interest in public health. My question is, I observed on the location of the current centers of the Public Health England. I'm worried the East Midlands, it looks like they have 2 centers, and the northern part of the country, I think there are only 3. Most of them appears to be in the southern part of the country. Why is it like that?
Okay, do you want to address that as particularly immediately for you, Kevin? Why only in the southern part of the country?
So you're speaking about the distribution of the centres for Public Health England? Well, actually, the centres are well distributed, and they're based on both recognised geographic and political boundaries, and they also are coterminous with many of the area localities for NHS England as well. So we're using standardised sort of clusters of geographic areas in the creation of Public Health England, but I'm not sure if that's what you're getting at.
Maybe 3 in the northern part of the country.
Okay. Yeah, so thank you. You're right that we can't be perfect in ensuring numerical sort of equity across the country, but this is based on existing political boundaries or recognized geographic boundaries. But whatever the grouping, the mechanism of working remains the same, which is close partnerships with local authorities, close partnerships with voluntary community sector, and ensuring that we're doing this work on implementation.
While you've got the microphone, there was that point about local authorities, local governments addressed to you.
Yeah, so that's such a great question, and thank you for asking that. Clearly, in this new environment, we do not performance manage local authorities or local government, and that's certainly not what you're getting at, but it's how do we ensure that there is mutual accountability in the new system so that the resources that are available are being used for the greatest impact. And there are a range of mechanisms in which we hope to do this. First is the ring fencing, and you know that we've been able to, and the Department of Health has extended the ring fencing for another year. Second, ensuring that we are understanding the local prioritization process, either through the strategic needs assessment, local health and well-being strategies, and working with our local colleagues on what's included, what's being prioritized, and what's being invested in. And then thirdly, ensuring that we are working with the local government association. So where we have concerns on any jurisdiction on how the resources are being spent, we use the existing infrastructures and partnerships to ensure that there is accountability and engagement on those resources. The devolution of responsibility will require us to find new ways to ensure that we are holding each other mutually accountable moving forward. Great question.
Okay, thank you. Yes, lady here. One there, and then one at the back. Yeah, in the middle, and one at the back, please. Yeah.
Shirley Kramer, Royal Society for Public Health. And it's more of a general governance question about the overall report. And if this report's considered a benchmark across those 53 nations, how will we be able in any way, shape or form to hold those countries to account around some of the awful statistics you showed earlier today? And the second part of that, is there any way you can incentivize any of those nations from a sort of European hub basis to do better, to do more, or at least to do something?
Thank you. We'll come to that in a minute, yes. Who's got the microphone? Yep. Please.
Aubrey Shyam from University College. I'd like to ask David about hypothecation using what Vic Health has done in Australia. What they did was they got the government to agree to take 1% of the tax from tobacco and use that for health promotion. And that had a whole lot of ramifications in various areas. And one of them, which is a lovely unintended consequence, was it recruited sports people to, instead of being ambassadors for promoting tobacco, they actually were ambassadors for health.
Mm-hmm. And final point, from the floor.
Oh, yes. My name is Anne-Marie Connolly. I'm Director of Health Equity with Public Health England. I wanted to ask the panel regarding, we're living in a time of a lot of austerity, it's called, or economic change, this country and across Europe. What sort of opportunities do you think this actually offers us to make these changes we want? We've been sort of feeling it's under a burden at the moment with all these changes, but can we do a glass half full bit? And are there some really critical things we might be missing an opportunity on at this time?
Thank you. All right, let's have incorporate some of those points, panel, in your closing remarks. David, if you could also just specifically address that question about hypothecated taxes, and just perhaps that final point about crisis and opportunity.
Well, I can kick off with that then. I mean, in terms of the crisis, I actually think it presents an awful lot of opportunities. First of all, and this sounds a silly thing to say, not to overlook what's happened in the past, because we keep on forgetting about that. So actually thinking about the crisis now to learn in the future as well. So going forward, actually learning from what's happening, sounds a silly thing to say, but we seem to repeat our mistakes. But from my perspective, and I have a little bias because I do a lot of work in the psychological health, mental health area, I think it is an opportunity to highlight the importance of trying to protect psychological health and well-being. And it does provide an opportunity because some of the most immediate impacts of economic downturns can often be on psychological health. And perhaps that sometimes goes under the radar more generally. So it does provide an opportunity from that point of view. And I think more generally, it provides an opportunity to think about prevention and promotion and thinking about resilience in populations, which, again, we don't tend to talk about as much when the sun's shining. In terms of hypothecation, I mean, there can be some advantages to it. I can think of an example, I think, from Thailand, where, again, there's a similar scheme where there is a health promotion unit or something, and they get the money from the sin taxes, essentially. Now, of course, there are benefits to doing that, and it means there are earmarked funds for health promotion and public health. The challenge, though, or the thing to be careful about, is that hypothecated fund isn't seen as the ceiling and the maximum amount that should be invested in health promotion and prevention. And so it should be seen as an additional source of revenue, but there is a danger, perhaps, particularly, again, in times of downturns, that budget may be seen as an acceptable minimum budget for policymakers.
Thank you, David. Thank you for your closing remarks. Kevin?
I think there are tremendous opportunities. I'll reflect on that. First, I agree to change the national narrative from focusing only to focus more on prevention and early intervention. And I know we've said this for many years. We should really use this opportunity now to do that. Second, I think it's a chance for us to challenge the ways we've always done things and to really think about promoting and using the opportunity for innovation. And then thirdly, to look at this as an opportunity for the integration agenda, to move from delivering simply isolated or stovepipe interventions to really think about the ways in which we combine interventions, the ways in which we create more holistic programming, and of course looking across the life course as well.
Thank you. And Ruth Hussey, Chief Medical Officer of Wales, some points there that you may wish to address in your remarks.
I'd like to pick up 3 areas as thoughts maybe to take away, not necessarily all solutions. The first one around governance and policy. We've talked about understanding the issue and knowing what's possible, what we should do about it. I think we've heard about the language we use and the need to communicate this is the people's public health. How do we do that? I think a dilemma or an opportunity is balancing the conversations which go, will it work? Will it work now? Can I put my energy behind it because I know there will be a result at the end of it, versus an approach which is an empowerment-led approach, which says actually wait and see, work with people, find the solutions in a different way. I think we need to actually find a way of keeping those 2 conversations aligned with each other and putting examples into practice is what I've heard today, how we align those imperatives, if you like. The second area is health and wealth. Overwhelming case, they're inextricably linked. Have we done enough to develop health and well-being as an economic sector? I'll leave that as a question. And the third point is this whole question of return on investment. Time is of the essence. People want to see results. We know there are things that could be done, that should be done, and we know other things will take 5 or 10 years to show benefit. Is there a need, at a time of austerity, I take the point entirely, to reframe the prevention agenda in the context of the difficult choices that are being made day in, day out? The whole concept of scalability, Kevin mentioned, when resources are tight, is an individual topic-based approach with a prevention service. Is that scalable? And how should we reframe a public health endeavour at a time of austerity? I think some opportunities to perhaps think differently about how we can make impact at scale, because that's what we need to do.
Thank you. And just some brief closing points from you, Michael, just takeaway message.
Well, firstly, I was thinking about Richard Parish's point about non-communicable disease being communicable through the social system. I remember a senior government official I think in this room saying that he'd heard that stress was a communicable disease and that he was a carrier. Knowing how this man functioned, I think he was Typhoid Mary. But Richard's point is a very important one. There is social transmission, and we need to find a better way of communicating. I don't quite like the idea of consumers and brands and marketing, but that just leaves me with a slightly bad taste in my mouth. But your general point I would agree with completely, of finding a better way than we have to date at communicating what all this is about that's in our report to the general public. The second point that hasn't really come up, somebody said, would high tax lead people to migrate? Well, maybe. I mean, every time this gets floated, somebody brings off the word processor, the standard argument. If you do this, we'll all leave. And where will they go? Where would they actually like to live? Where would be the preferable place to live? What I see is people flocking into London. All the wealthy housing is being bought up by foreigners who are flocking here. So, the more important question is the fact that we're exporting bad working practices. We, and I use the word we, should look at the collapse of a factory in Bangladesh and say we are complicit in that. We like cheap clothing. And our desire to have cheap clothing is causally linked to people dying in factories in Bangladesh because of the inferior working conditions. Now, I don't pretend to have the solution to solving this, but I do think that if we put our minds to it, we'd find a way to explain to, for example, workers in Europe, the reason they're losing their jobs is so we can, forgive me being a bit melodramatic, create bad working conditions in Bangladesh so we can have cheap clothes. I think we need to address these issues. So I'm not concerned about a few rich people finding somewhere else to live. I'm much more concerned about the adverse impact of globalization on working conditions. And the third thing, Anne-Marie Connolly's question about austerity and the challenge and opportunity. The problem is, and people have made this point, they say never waste a good crisis. And the crisis is being used to create real changes in the way we organize our affairs and in the way we fund things. So there are two ways to think about austerity and the crisis, the financial crisis. One is a negative and one's a positive. Mm-hmm. Let's avoid the negative, but agreeing with what Ruth said and with what Kevin said, let's take it as an opportunity to think how we want to use our slightly straitened resources in a way to benefit the whole of the population.
Thank you very much indeed, Michael. And so now, thank you. For our closing comments, of course, have to go to Dr. Agis Souros, Director of the Division of Policy and Governance for Health and Wellbeing at the WHO Regional Office for Europe, who, of course, commissioned this review, chaired by Michael, on the social determinants and the health divide in the WHO European region. And Agis, perhaps if you go to the lectern to make your closing remarks and to incorporate the point made from the lady there in the front about, you know, you've made these marvellous recommendations in this marvellous review on how you've got to get all government actors and other stakeholders, the whole of government approach to health. But, you know, how can you hold the 53 governments accountable? How can you incentivise them as well? So thank you very much indeed.
Thank you. Thank you very much. And I would like to start by sharing with you something that has stayed with me, and it was many years ago. In London, I watched a panorama program, and there was a journalist standing on one of the hills in Sheffield, and he was saying, the children that are going to be born in that part of the city are going to live longer, they are going to have access to better education, they are going to have better jobs and better opportunities in life. And the children that will be born in that part of the city, they will have shorter lives, miserable lives, worse schools, access to worse services and less services, education, and so on. And I thought it was so powerfully presented. It was simple. It was something like that I came across when I visited Wales a few years ago in Cardiff, when I was presented with a publication on the tale of two cities. It was the city of the haves and the city of the have-nots. And there is something about communicating the evidence to those that we want to attract. So first, I would like to say that one way of addressing this issue and creating a movement for change is, in fact, what we have done in the last few years by collecting the evidence, but also locking this evidence inside the Health 2020 policy. So the first answer to Zainab and to the colleague who put the question is that these 53 member states have actually politically signed up to the Health 2020, where objective number one is working on the determinants and the inequalities, on the governance and the other big priorities. You may say it's a piece of paper that they sign, but this creates legitimacy for change. This creates commitment. This enables leadership. And then, of course, at the level of the organization, we work with the member states. As you are probably familiar, we have a center in Venice, which is led by Erio Ziglio, and a group of colleagues working on developing the tools and working in countries developing capacity to implement inequalities and to develop policies for social determinants. So, yes, it's not enough to sign a piece of paper. It's not enough to go to a kind of great celebration of the launch of a study. It's a combination of issues. And we understand that. We understand the language, we understand the commitment, we understand the leadership, we understand the capacity, we understand the legitimacy. That's how a movement can be created. When you know, even if you are a reluctant person in the context of these debates, when you know your neighboring country or countries are doing something about it. As a Minister of Health, you come to our meetings, you're not exactly on the spot, but you don't have anything to say when others are reporting progress and action. So there is something in Europe. But we have to repeat what we've done here in many places. It's not enough to have this great debate here. Can we take this in other countries? Yes, we are planning to do this now in the Nordic countries, in the Baltic countries, in the Central Asian countries. We need to take these ideas and concepts out there to be debated, to be understood, to be embraced. So this is really what this is all about. Creating a momentum, creating tools, creating engagement, and following up. As a colleague said in the previous panel, there are countries, I wouldn't say they deny they have inequalities, but there's no information to tell if they have inequalities and to what extent. Even engaging them to doing so is going to be a great step in the right direction. The last thing I wanted to say is that we have been to so many meetings. We have listened to Michael and to other colleagues presenting the evidence on the social determinants. But we have to get out of the public health community. I mean, I would love to see this presented in an education sector or in other sectors in a party political conference. Why not? Take this review and take these issues and say, what do they mean in terms, what are the implications for the way we prioritize our policies if health is as important as it is? And of course, it is true that austerity today gives us great opportunities, not because we go to ministers, because they come to us. And they say, we are pushed now by our ministries of finance to make priorities, to cut down our budgets. How do we do this without hurting the population? What's the best way to invest? So there is much more to come, but I would like to say at the very, very end that from WHO, Susanna really wanted to be here till the end. We have some visitors tomorrow and she had to prepare that we are grateful, first of all, to the Department of Health, to the Minister, to Ray and all the colleagues from the department that have invested and helped in organizing this event, to Michael Marmot and his great team, and Peter and Felicity, and all the colleagues who have put so much effort in doing this here. I would like to also thank the WHO team, Osa, Chris, Johanna, and Franklin, Ina, and so on, who have been here with us to organize this meeting at a short notice, and of course our great moderator, Zainab. So thank you very much.
Conference over. Have a very good evening. Bye-bye.